Hi there, and welcome. My name is Jeff Bell, and on behalf of our Deconstructing Stigma team, I'd like to thank you for joining us today. We're calling the session OCD 101, and our goal is to share what you should know about obsessive compulsive disorder and the many misconceptions about it. While a lot of people might think that OCD is just about quirks, it's actually a serious, often debilitating, but treatable mental health condition. So let's talk about OCD, the many ways it can manifest, and how it's diagnosed and treated. We have a special guest expert here to help us do all of that. She is Dr. Lisa Coyne, a licensed clinical psychologist and assistant professor of psychology in the Department of Psychiatry part-time at Harvard Medical School. She is an internationally recognized acceptance and commitment therapy trainer and a prolific author and very popular speaker on the topics of anxiety, OCD, and parenting. Lisa, it is always such a pleasure to chat with you. Thanks for being here today.
It is my pleasure to be here again. Nice to see you,
Well,
Jeff.
likewise, let's start by teasing out the O, the C, and the D in obsessive compulsive disorder. Obsessions, how would you define those?
Obsessions are recurrent intrusive thoughts. So these are thoughts or any sort of mental experience, which can be an image, it can be a sensation. Examples of that are incompleteness, things are not even, existential dread, doubt, etc. But the hallmark of this is that they are recurrent, they occur over and over, and they are unwanted. So that's the obsession category in OCD.
Okay, and then let's talk about compulsions, the C.
So the C means compulsion, which is a ritual, which is a behavior that one repeats to fix, mitigate, make better, nullify, neutralize any of the obsessions that happen. And there's usually a dose response relationship where when you have a specific obsession, sufferers need to engage in a particular specific ritual, usually in sometimes in a just right way.
And the all-important D for disorder. Why is that so key to this whole cycle that we're talking about?
Because when an individual suffers with OCD, it causes functional impairment that makes it difficult for them to work. It gets in the way of social relationships and connection with others. It gets in the way of them living lives the way they want to, and it also causes significant distress.
We'll talk a lot more about each of those components throughout the session here, but I want to ask a little bit more about the big picture. What do we know about the prevalence of OCD?
So about 3 million people in the United States have OCD, believe it or not. 1 to 2% of kids. So it's quite common, actually, more common than one knows. And so you would expect to see 1 in 200 folks who have OCD. So it's as common as things like diabetes, actually.
Is the diagnosis missed a lot?
It is very frequently missed. People don't, when people are suffering from it, it usually has an onset in the teen years, but it can have onset in childhood or older than that. And people don't necessarily recognize what it is. They might think it's an anxiety disorder. They might actually be ashamed of some of the thoughts that they're having or self-conscious and unwilling to talk about it. They might try to deal with it by just keeping it a secret. In addition to that, on the treatment provider end, treatment providers do not, for the most part, have specific training in how to detect and assess OCD. And so that's one of the important things to know when you are starting to struggle with this, that it's important to find providers who do have that explicit training in this.
Absolutely. And again, we'll talk more about that diagnostic process as well.
Mhm.
Any thoughts in terms of where the field is with causes, genetics, environmental factors? What should we know?
Such great questions. And it tends to be heritable, which means that if you have a relative who has it, first degree relative, someone close to you in your family, you have a greater likelihood of having it. When we see children, there's a 50% chance that one of their parents will have OCD as well. So that doesn't mean it's entirely genetic. It doesn't mean it's not. And I think that the best that people can come up with is that there's multiple sort of streams that you can get it. For example, There is an autoimmune version of OCD that is triggered by the strep virus called pandas and PANS, which is a variant of that, where it is related to immune functioning, it's related to infectious disease. So there's a lot of different ways this shows up. That's a rarer form, but it's absolutely something that's heritable. And once individuals start engaging in these behaviors where you start to see this sort of obsession compulsion um, pattern, the disorder starts to kick in and take hold.
Okay, this is where things get a little complex, both clinically and for folks who are just trying to figure out what's what. OCD is often confused with other related disorders. Let's start
Mhm.
with a very common piece of confusion, which is the fact that OCD is now no longer considered an anxiety disorder. Could you make that distinction for us and why it's been pulled out of that category?
Yes, and it's tricky. That's true that it is tricky because OCD can have elements of anxiety. It can cause sufferers lots and lots of anxiety. However, the hallmark of this is having recurrent intrusive thoughts that are beyond anxiety, right? So it can be a sense of dread, it can be a sense of guilt, a sense of doubt, and things like that. So that's one reason. The other reason, of course, is just this very systematic relationship with repetitive behaviors that occur when these thoughts come up. Whereas with things like anxiety, right? If I am anxious about a social situation and I fear social evaluation, for example, in social anxiety disorder, I might simply avoid social interactions broadly. But if I have OCD and I think that perhaps I have said something that's offended someone, and I'm just consumed by that thought, I might engage in a ritual to check and to see if I can fix that. And so there's a slightly different flavor of OCD, and it's classed with other disorders like body focused repetitive behaviors and things like that, which means skin picking, hair pulling, things like that.
What about hoarding? We often hear about hoarding associated with OCD as well.
Hoarding is considered a variant of OCD, and hoarding occurs when individuals have significant difficulty getting rid of items of any kind, but sometimes things that people would think of are trash or are meaningless items that don't seem to have any particular value, social value. And what the research has shown about hoarders is that they have a lot of difficulty discriminating between what's important and what's not, a lot of doubt around how to make those decisions. And what ends up happening is that they end up keeping items just in case they might need them, or because those items remind them of something that might be important to them in their lives. Um, and their homes end up getting more and more full with these items, some to the point where it's no longer a livable, habitable place. So that is definitely a different form of OCD as well.
Lisa, you mentioned anxiety disorders. There are a number of common ones. Real quickly, can you sort of run through what those most common ones are, just so we have that
Sure,
vernacular as well?
absolutely. So social anxiety disorder, that is the excessive fear of feeling like you might embarrass yourself, that you'll be rejected, that you might do something that is makes you look ridiculous and that people will judge you for it. There's generalized anxiety disorders, which is characterized by excessive worry about most things. More than you would think that the average person would worry. And that worry, of course, is a cognitive activity which actually just feeds on itself and gets more and more. So that's a really difficult one. There's separation anxiety disorder in children and teens. We sometimes see it in adults, but less frequently so. There's panic disorder, which is characterized by having a panic attack which is out of the blue. This is not something that's triggered by a specific event. It just happens. And it's characterized by high anxiety sensitivity, which is fear of anxiety, and also watchfulness about around physical symptoms that might be perceived as precursors to a panic attack. That sometimes comes hand in hand with agoraphobia, which is difficulty leaving one's house for fear of having a panic attack in public and not being able to get away. So, one more would be the specific phobias. So, for example, I have a specific phobia of heights. And unfortunately, it shows up in places that I really like to go, like hiking on cliff edges and things like that. So it's something that I continue to try to face. But a specific phobia is a fear of a very specific and constrained thing. Like, for example, needles, doctors, heights, dogs, spiders, etc. There are any number of these, and that fear is debilitating and it causes you to not be able to move in your life in areas that have those things. So there's a lot of avoidance there.
I imagine that gives you a lot of empathy for your patients.
100%.
Yeah, yeah.
100% it does.
Let me ask you about OCPD. I don't want to confuse things any more than we
Sure.
need to, but that term comes up as well, and that's talking about a personality disorder. Can you explain the distinction?
Yes. And so when we say personality disorder, what we are meaning is a set of behaviors that are very stable across different settings. They're very hard to change. Some people think of personality disorders as having a trait-like feature. I prefer to think of it as in behavioral terms. The difference between OCPD, obsessive compulsive personality disorder, and OCD is that an individual who has OCPD believes that the ritualized way they approach things in their life is absolutely the right way to do it, and everybody else is wrong, even though attachment to this right way of doing things may disconnect them from people who are important to them, make it very difficult for them to move through their lives and get things done in a timely way that they want to. They still have this attachment to it needs to be like this, right? Whereas OCD sufferers do not like having to do rituals. They do not want these recurrent intrusive thoughts to continue happening, but they feel like they have to because they don't very often know what else to do. And because engaging in those rituals to some degree, at least in the short term, appears to work for them. And I'm sure we'll talk more about that.
We will. And Lisa, I would be remiss not to bring up a shared pet peeve of ours from past conversations. I know this to be the case, and you know where I'm going with this.
I
This is
do.
the misuse of the term OCD. It is not an
uh,
adjective. It does not mean
no,
fastidious or anal retentive. Why is
correct.
that an important distinction for us to highlight here?
Sufferers who have OCD really suffer. And it is an incredibly painful disorder to struggle with. And when they hear people who do not have the disorder saying, "Oh, I'm so OCD. I really like my stuff to be, neat," it is incredibly hurtful and offensive to them. And when we see businesses sometimes using OCD in a jokey way, it's again just insult upon injury. So what I would suggest to people is really be mindful of that because it is a complex disorder. It is not fun and games. It is treatable, and it takes an incredible amount of heart and courage to walk through the treatment for it for sufferers. So I would hope people would be mindful and not say things like, it's so OCD.
Excellent. Thank you for joining me on the soapbox for that. And
My seriously very important.
well, on that note, it's a good segue into the next component of this conversation, which is the impacts of OCD. Let's talk about what can happen with untreated OCD, because it's important to know the stakes here.
So OCD is not a disorder that really goes away on its own. It is something that really requires treatment. And what can happen if you don't treat it is it can become debilitating and it can have cascading functional impairment. So imagine this starting when you're a child. You don't know what it is. You don't get treatment. And by the way, because of the absence of or the shortcoming, or not shortcoming, the shortage of specifically trained treatment providers, most people who struggle with OCD, it takes them years to find a provider who actually knows what they're doing. By that time, they have struggled with this disorder for years on their own. And so when you have something that you feel like you've been trying to battle on your own, you feel like you should be able to handle it, what happens then is you feel full of shame. You start to wonder what's wrong with me that I can't fix this, right? And so it's really, really important to try and um, get treatment if you can, and get it early on, as early as you can, and make sure that those providers that you're talking to know what they're doing.
Before we get into the treatment process, because we do
Mhm.
want to spend a lot of time going through that and the various options, let's talk first about recognizing OCD, both as a layperson in terms of red flags that you might see in yourself or others, and
Mhm.
also from a clinical standpoint. Let's start with the non-clinical part. If I am watching this and wondering whether or not I have OCD, what are
Mhm.
some thoughts for that person to start with?
So, if you start noticing that you're having any sort of mental experience, like a recurrent intrusive thought, and it could be about maybe things are contaminated, maybe it might be an image that you don't like that could be scary to you, or it could involve harm of others, or the risk of you losing control and being impulsive and doing something dangerous or embarrassing, for example. Or you might have even taboo thoughts that arise in you, and you don't know why they're there. It's not anything that you want or like, and yet you can't find yourself the ability to stop thinking about these unless you engage in some sort of ritual. And one thing I didn't mention earlier is that rituals can be behaviors that you can do, right, outside of your body, and they can also be thinking rituals or cognitive
Mm.
rituals. Like common ones might be trying to replace a bad thought with a good thought, saying something that's a superstitious saying that you think will um, mitigate something else, right? Or even rehearsing things in your mind, like, did I offend that person? And checking on that. So if you find yourself having these mental experiences and also feeling like you have to engage in these sort of like ritualized behaviors afterwards, you might want to see if you have OCD, right? And especially if this is causing you significant distress and it's getting in the way of you living your life in the way that you would wish to live your life.
And if I am somebody living with or associated with another individual that I am concerned about that might have OCD, what might some red flags be in that situation?
Rigidity in how things need to be done, continually asking for reassurance, getting really upset if that rigidity is not met. So, one thing that happens to significant others and families who have individuals with OCD that they're living with or raising is that very often parents or partners are pulled into the cycle because OCD is very much an interpersonal disease. And so the sufferer may be asking for help doing rituals to make things easier, making sure everything is really clean, not contaminating things, giving reassurance repeatedly, even if, and that reassurance not seeming to work very well, and getting incredibly distressed if the sufferer is not met where they want to be met.
So let's move this into the clinical sphere now. Let's
Mhm.
say that I have decided perhaps I might have OCD and I want to talk to somebody like you who's an expert in the field. How would you go about diagnosing me?
Okay, so the very first thing I would do is resource use. So let me just start there. And I want to suggest going to the International OCD Foundation website, iocdf.org. That is an excellent and perhaps the best place to start to gather resources and evidence-based resources and learn about OCD, including learning how it's assessed, diagnosed and treated. So let's start there. So if someone came to my office and thought that they had OCD, there are a number of evidence-based measures that are used. There are checklists that you can fill out, but mostly what we like to use are measures. One of my favorites is called the Y box, the Yale Brown Obsessive Compulsive Scale, which is an interview given to you by a professional trained in the assessment and treatment of OCD that goes through obsessions, compulsions, and the level of severity, the distress, the functional impairment that's going on. This measure is available for both adults and children. Another one that we routinely use in our clinic is called the diamond, and it's a similar type of measure, but it's broader. So it also encompasses anxiety and mood disorders, as well as things like executive functioning, autism, etc. And substance use, trauma, all of the other things. And we did not mention PTSD as
Mhm.
also another anxiety disorder that's related to trauma. But it's really the best way to find out if you have OCD is to be given and ask for an evidence-based measure by someone who's trained in how to do this. So you can interview unstructured, but that's not really the best care that you can have.
Co-occurring conditions, that must
Mm.
complicate things for you as a clinician trying to tease out what's what. Without getting us too far off into the weeds clinically, what should all of us know about common co-occurring conditions with OCD, for example?
Yes, and there are many, and it varies across ages. So, mood disorders are common comorbid conditions, as are anxiety disorders with OCD. And sometimes they are distinct disorders, and other times they are related in the sense that someone has grown very depressed because they're very weary of having to suffer with this condition without treatment for a long time. Other things that are really, really important, I think our field is going through a sea change where we are learning much about what it means to be a neurodivergent and neurodiverse individual. So, considering autistic persons, 17 to 37% of those estimates suggest also have OCD. Also, about roughly, some estimates suggest that about 30% of individuals with OCD also have executive functioning disorders, for
Hmm.
example, attention deficit hyperactivity disorder. So, comorbidity in OCD is the rule rather than the exception. Um, and so, it's really important when people go for their diagnoses that they are also assessed for some of these other conditions. Otherwise, something might be missed.
Let's move into treatment. This is such a key part of the discussion
Mhm.
because, as we noted at the very beginning, Lisa, and this is a message we need to keep putting out there again and again. OCD is treatable. I mean, that's the
It
good
is
news.
treatable.
Let
Yes.
let's talk about that treatment. What's involved?
So, the treatment for OCD that works the best, and this is across multiple decades of research, is exposure and response prevention. Okay. And it is really important that if you really want to get treated well for OCD, that you find a provider who is specifically trained in that, and the majority of their work is treating individuals with OCD. Okay. So exposure and response prevention is a behavioral treatment. Clinical trials suggest that they looked at about 12 weeks of treatment, right? Although treatment can go on for much longer than that, depending on how engaged the individual is, comorbidity, etc., right? There's also medication for OCD that is an evidence-based treatment, right? So SSRIs, for example, which are also used for mood disorders, are very helpful for OCD, especially when they are used in concert with exposure and response prevention. Okay. And if you had to choose, I would say prioritize the behavioral treatment because one way or the other, treatment involves learning to change your relationship to these recurrent intrusive thoughts that come in such that you don't engage in rituals, right? So when we talk about exposure, we talk about how do we willingly choose to face this fear or discomfort, this scary thought that we're having, or this sensation or belief without engaging in a ritual. That's the RP part of ERP, the response prevention part. You cannot do exposure without response prevention. And that's a really key piece. Um, so making sure that you are willing to do the treatment and walk through it, if you are, it works really, really well for the majority of people who take it. There are other treatments that also have an evidence base, including acceptance and commitment therapy, which is also an exposure-based treatment. It is sometimes used in concert with ERP, sometimes instead of, depending on the individual. There's also inference-based cognitive behavioral therapy, which is a newer way of thinking about OCD that has begun to build an evidence-based. Still, the central and best treatment for OCD is exposure and response prevention.
Let me ask you to explain the science behind that. And again, in layperson's terms, but um, you're asking me as a therapist to sit with my anxiety. That's not fun. And I speak
No,
as
it's
somebody who
definitely not
actually
fun.
has been through OCD treatment.
Yes.
It's not fun. And that's why ACT can be really helpful as a different layer, which we'll come back and
Amen.
talk about. But what's the concept here? I mean, is my anxiety going to dissipate on its own if I sit with this anxiety, or what do we know about that?
Wow, how long do we have? So, so traditional models of exposure and response prevention were based on the idea that if you face a fear, right? Fear loosely, when I say fear, what I mean is that discomfort that comes with recurrent intrusive thoughts, right? The obsessions. Over time, you will, and if you face that and you don't engage in ritual, over time you will habituate, which means the anxiety will diminish, right? You'll experience these thoughts, they won't have that same bite, right? And you have made it through your OCD treatment. It is challenging because you have to be willing to face your fear. You have to trust the treatment process, which is a hard sell for people sometimes. And yet, when they do it, it works really well. Now, that's the traditional older research on ERP. Newer models of how ERP works call into our thinking this term inhibitory learning. And
Hmm.
basically, I'm just going to say this in lay terms. We used to think if you face a fear and you don't avoid it, you kind of break the link between the fear and your behavior and you unlearn in some way. We don't ever unlearn anything. So we don't
Mhm.
erase any learning. What we do is we learn new things. We have a corrective learning experience, right? So if you have an expectation that if you touch something that's contaminated, you're going to get seriously ill, right? And then your treatment is slowly and gradually getting more, deeply in touch with whatever this contaminated substance or thing is, and you don't get ill. You're not unlearning that association. What you are learning is a new association, right? Like that, I can touch this and I don't get ill, even though I still have this fear underneath that, like, maybe I will, right? And so the goal there is how do you supercharge and make more potent that new learning? And there are different
Mhm.
ways that we can do that. And again, you have to be a trained provider in ERP to really know how to do this. But that's it in a nutshell.
Well, let me put a finer point on what you just said there, too, in terms of you need to know how to work this process as a
Yeah.
clinician. So, as somebody with OCD or a family member of somebody with OCD, when we are looking for treatment providers, you mentioned this earlier, but it's really important to again, put a finer point on this. you need to stress in your search that you are looking for somebody who understands this process of ERP. Because if you go out there on the internet and just look for providers who treat OCD, you often find that that's one of 35 conditions that they treat. They may or may not do ERP. So tell us a little bit more about that concern.
Right. So if you are not well trained in this, you can go too fast. You can mistake how to set up exposure and response prevention exercises. You might not know how to build a hierarchy. You might not know how to engage your client's true willingness. And you might miss, for example, what the client's core fear is, right? So what core fear refers to is what's the fear underlying this OCD ritual. So for examination, if I keep talking about contamination, let's say I have a recurrent intrusive thought that whenever I'm on an edge of something, I might jump. What if I jump? Right? And the core fear is not falling necessarily. It's not even dying. Maybe it's just, oh my gosh, what if I lose control of myself? And if you don't understand that that's the main fear, you might set up exposure exercises that don't really trigger it, you know? And so that's important. So questions that individuals, when you're looking for a therapist, should ask are, tell me about what approach you're going to use. Make sure they say not just cognitive behavioral therapy, but exposure and response prevention. Ask them what percentage of their practice is OCD, right? If they're like, oh, once in a while I see a client with OCD, that's not what you want, right? You want somebody who like at least 50% of their practice, at least is that. Um, Tell me about your training in OCD. Did they just do a webinar? Did they read a book? Or did they actually go through and have significant training and or consultation from more seasoned clinicians in how to treat OCD, right? So these are some questions that it's really, really important to ask. Ask them how they assess it and how they measure progress. So if they tell you, we'll give you the Y box or the CY box if you're a child, great. If they measure your progress with those measures to see, like, are you avoiding things less? Are you doing more things that you care about? That's great. Those are really important things too.
It can be intimidating for somebody with an anxiety disorder or OCD or any other challenge, or for that matter, for anybody, to
Hmm.
question a therapist that way. Um,
Yes,
can you speak to that from the therapist's perspective? I assume you've never been offended by a patient asking you a question about
never.
whether or not you do X, Y, or Z.
Never. And what's more, I'm never offended or frightened of saying, you know what? I actually don't specialize in that. I'm so sorry. Let me help you find someone else. That's really important. And if I could have listeners take one thing away from this, it would be please be good consumers. Please
Mm.
trust us. And if if you are interviewing a therapist and they get upset with you for asking these kinds of questions, they are not the right therapist for you. I
Run.
promise. Run. Yeah.
Yeah.
I mean, I would never. So as a clinical psychologist, I'm bound by an ethical code that it's unethical for me to treat beyond the areas of my competence, right? And I am grateful that I have a treatment that has such a strong evidence base that I can point to and say, not only do I have actual data that this works, I also have training in this, right? That's really important. So definitely ask the questions. And if it's hard to ask in person, have someone else ask for you if you need to. Write them down, right?
Yeah. Yeah.
And do not hesitate to really be a good consumer, even if you feel a little daunted by that, a little socially anxious about that. It's so important, and you are going to, this is your life,
Yeah.
and you deserve the best treatment that you can get.
Absolutely. And thank you for sharing that perspective. I think that's important for everybody to
Yeah.
hear. Levels of care. Let's talk about those briefly before we move on. Sometimes people are put in residential programs.
Yep.
Sometimes folks are doing intensive outpatient work.
Hmm.
Explain what those levels of care are and how they factor into the treatment process.
Sure thing. So we usually start with simple outpatient work, which is once a week work, right? And this works well for OCD, where an individual is very willing to engage in the treatment, is has been given a clear understanding of what's involved, and is willing and able and does practice homework assignments outside of treatment in a systematic way and holds themselves accountable. When you have all of those things in line, you are really on a good path. Sometimes it's hard for people to practice outside of sessions. Sometimes their willingness is not so strong. It's scary, they need more support. So at that point, we might think about, and if they're not making gains after 6 to 8 weeks of treatment, you might even do it sooner than this. You might suggest a higher level of care, an intensive outpatient program, which is more than 2 sessions per week. Sometimes it's 5 days a week, etc. Different programs in different areas are slightly different, and you have more clinical support on a daily basis to help you practice the skills that you're being taught and that you're learning in treatment. So sometimes people are very severe and they really are struggling to access treatment at all. And it's just they don't feel, perhaps they feel like it's impossible for them to resist engaging in compulsions. Perhaps it causes such significant distress, they just feel like they want more support or they need more support to move forward. And less intensive levels of care have not worked, right? Perhaps they've also tried medication, and that has also not helped make a dent in this condition. If those things are going on, residential treatment is an option. And what this looks like is anywhere from, it really depends on the program, and different programs have different mean durations that their clients stay. But you should think about anywhere from 2 to 4 months, right, of treatment where you go to a facility. McLean Hospital has one. There are several others in the US. And you have specific treatment for your OCD that involves addressing your OCD. Perhaps you have some comorbid conditions that require some support as well. They may have other elements in their program for that. But the heart of the matter is to really give you 24/7 access to sustained support and encouragement to engage in this practice of facing the things that are challenging without engaging in response prevention.
At this point, Lisa, I want to zero back in on some of the actual manifestations of OCD, because
Mhm.
this can be confusing as well. I remember when I was going through my trials with OCD, my challenges were primarily around checking and harm obsessions.
Yeah.
And
Mhm.
I had a dear friend who also had OCD, but she was a quote unquote repeater based on her compulsion, needing to repeat things. And I
Mhm.
remember thinking to myself, I have absolutely nothing in common with this friend of mine.
Yep.
And yet it really boils down to it's not about the content. Can you speak to that?
Exactly.
Because I think
I
this
can.
confuses a lot of people.
Yes. And I think that's such an important point that you can have two people with OCD who look completely different. They look like it's a completely different thing. But the thing that is the same is this obsession and compulsion relationship where you have some sort of unwanted experience, doubt, fear, discomfort. And there is a strong, sometimes unavoidable urge to engage in a ritual or compulsion to make that better, right? And so for you, it was one thing. For your, it was checking, and for your friend, it was repeating. So on the face of it, the topography, how it looks, it might look completely different, but functionally, it is exactly the same. right? And that's why content isn't thought to matter. What is your obsession doesn't matter, right? One thing I will say is that OCD can be really tricky. And there are some forms of OCD where people are, for example, fears that you might harm someone you love, physically or sexually, fears that you might engage in an inappropriate behavior, or that maybe you have and you don't know, right? With an adult or a child or even an animal. And I'm speaking about these because when individuals have these kinds of experiences and thoughts, they are so full of shame. They don't know what it means that they're having these kinds of thoughts. And they're terrified to tell anyone about it, which is a huge barrier to care. And so, what I want to tell you, if you are having any one of our listeners who's having those experiences, if you go to a trained provider, these are all things we have all heard before. They do not frighten us, and we know what they are. Okay. And help is there. It doesn't mean anything. It's OCD. And so I just really want to say that because I have had countless people be terrified and have to ask, is there anything I could tell you that pops into my mind that would make you not want to see me, or and it breaks my heart, right? It's really important to know this, right? And if you don't believe me, check out the International OCD Foundation.org and you will find lots of great information on those pages.
And Lisa, let me circle back to something that you have touched on, but I think it's very important as well as we sort of tease out what's what. Mental compulsions. This can be
Oh yeah.
confusing because there is
Mm-hmm.
a difference. And again, I know this from my own
There is.
experience between ruminating and obsessing. The ruminating part I have done as a compulsion because I have some willpower involved in whether or not I sit there and replay in my head something over and
Over
over
and
again
over and over again.
versus the thought that I can't stop from happening. So there has been sort of a
100%.
misconception for a lot of people that there's no such thing as, um, or that there is something with just pure obsessions and no compulsions attached to it. Speak to that if
Right.
you would.
I will. So years ago, there's a term that's since fallen out of favor called pure O in quotes, OCD. And what that meant was that there individuals can have only the obsession part of OCD, and you don't really see any rituals or compulsions. That's incorrect, and that is why that term and label has fallen out of favor. What we do know is that rituals can be things you do in your mind. For example, if I am struggling with the doubt that perhaps I have done something wrong in the past to harm someone, but I just can't remember, my ritual, my cognitive ritual might be going over past events over and over and over and over to try and figure out, could I have done it? But when could I have, am I sure? Check. So that's one. Another one is a common cognitive ritual, I would say, is you might have OCD around, are you sexually attracted to one gender or another, or to inappropriate others? For example, someone in your immediate family or a child, right? And so a common form of cognitive ritual is checking, do I like this when I have this thought? Am I aroused when I have this thought? And repeated checking, of course, can also trigger arousal, which then is even scarier, but it's OCD, right? So there is no such thing as pure O. There's always in OCD, in this disorder, there's always a compulsion of some kind or another. That being said, it is not uncommon for individuals to avoid situations that might trigger the need to ritualize entirely. For example, if you feel like things outside your house are contaminated, but inside your house is safe, You might just avoid going outside entirely, and you don't necessarily report any compulsions that are going on inside your house, right? Because you're not putting yourself in those situations.
Yeah.
So I think that it can get, and again, this is more data about why you really want to see a trained provider. But back to your question, cognitive rituals are voluntary, volitional things that we do in our minds to fix whatever the OCD thought was, the obsession was.
In the time that we have left, Lisa, I want to zero in on a couple of different groups in our audience, potentially, one being loved ones and the other being clinicians. Let's start with the loved ones. Um, to what degree should they be involved in the treatment process, in whether it is explicit in terms of bringing them into the treatment session or implicit in terms of the support that they might provide?
So OCD is an interpersonal process, and whether you are an individual who has kids with OCD, partner with OCD, friends with OCD, at very minimum, I would suggest learning as much as you can about the disorder so that you're conversant with it, and so that you can be a safe place for your person to disclose, talk about things, and that you're not for lack of a technical term, freaked out by
Yeah.
this. You know, like if you want to be a supportive person in that individual's life, learn everything that you can, right? And again, we've talked about some resources like the IOCDF Foundation that you can learn this stuff. Now, in terms of treatment, it can also be incredibly helpful if you're involved. So, with children and teens, parents may be involved in very different ways. With younger children, they might be involved as in terms of helping to support exposure practice beyond sessions, helping to communicate differently about the OCD, to express empathy and also confidence in the young person in their ability to learn how to handle it without avoiding it, without engaging in rituals, and also to set some guardrails around the upset that will happen when kids start to face this in treatment. Now, with teens, it's going to be more collaborative than directive, and yet it's still incredibly important for parents to be involved, right? So we see sometimes over involvement for parents in the teen years, which is more, it's, you see parents who are trying to almost do treatment for kids and get them to do the treatment. And that can be, if you've ever interacted with teenagers, that's sort of incendiary and can sometimes cause kids to push back and be less interested in doing treatment. So, being more collaborative, engaging in supportive communication is very, very important there. And same thing for young adults and adults, right? One thing that OCD can do in adult relationships is the whole relationship can be focused on how do we manage this OCD to make it easier for this person, which of course takes away opportunities for the sufferer to learn how to handle it on their own. And
Yeah.
it can really cause problems in the relationship because it's almost like there's three of you in the relationship, you both and the OCD. And so,
And one thing I've learned, Lisa, is that this
yeah,
is really tricky for the loved one because,
absolutely.
it's our human nature to want to relieve the anxiety of those who we
Yep,
love. And
of
so
course.
my wife might be wanting to provide the reassurance to make me feel better, and yet that sort of feeds the cycle if we're not careful.
Exactly. And so, one shift in thinking about that is to be loving means to trust that your person who you love can learn and beat their OCD. And that might look like not protecting them from their fear, not making rituals easier to do, not making sure all surfaces are clean and not contaminated, right? So it sounds counterintuitive, and yet it is the most fiercely compassionate thing that a partner could do. But Jeff, it's exactly right. And I'm so glad you said this. Like it is our natural instinct to not want the people we love to suffer. And so it makes perfect sense for people to get pulled into OCD rituals. And it's important if that is you, listeners, that you don't beat yourself up for that. You're only doing what feels right and what all of us would do without in the absence of really knowing and having training. And what do we do with this?
And all this speaks to, again, the importance of working with a trained professional. On that note, I know that we often have clinicians in our audience. I want to ask you to speak to those who are here earnestly because they want to learn more about how they can treat OCD. And maybe they really resonate with what you're saying that, if I'm not the right therapist, I'll refer you to somebody who will. What would you like a generalist, for lack of a better way of describing this clinician, what would you like them to know about A, what kind of training is available for them, and B, any kind of guidance for when they might want to refer out?
Absolutely. First of all, thank you for being here and learning about OCD. I think that's amazing. Um, the second thing is, I would say that there are many ways to get trained in OCD treatment. There are a lot of books out there. Perhaps the best thing to do is, again, check out the International OCD Foundation.org. They have a behavior therapy training institute, which runs every so often in person at various places in the US, also online. And they are always, always working on improving that. They have advanced clinical forums for those of us who have been doing this for a long time and we want to make sure our skills are honed. They also have pediatric offerings, and in addition to their adult offerings. In addition to that, a number of us who have had this training are training ourselves, or we do clinical consultation. And if I had my druthers, what I would say is find a clinician whose primary practice is about OCD and they have a proven track record of teaching and training, and go do consultation, right, with that group. Do your courses. MGH has some wonderful courses as well on OCD, um, and vet them. There's also a few other resources that have been developed for clinicians who are really, really seasoned in this. Um, Among them, Kim Quinlan has a school called CBT School. It's really excellent. Natasha Daniels is a clinician who works exclusively with children and teens. She has a really wonderful community with lots and lots of resources. So if you're a clinician or if you're a person who has a child with OCD, that's a great cache of resources for you, because it's stuff that you can give to your clients or you can use directly as a parent. So I would say get some ongoing consultation and get yourself in a consultation group where you can hang out with other clinicians who do this. That will amplify the number of cases that you hear about and the various presentations that you might see. And it will really help you to share that knowledge with other clinicians that you gain as well.
Lisa, I want to wrap things up on a positive note. And I know you can do this because you have seen lives turned around with the proper treatment for OCD. What we
Yeah.
just shared can be especially daunting for somebody new to the subject, learning about it for the first time, for example. There are a lot of confusing components. It can be debilitating. Speak to us about some of the success that you have seen through
Mm.
effective treatment over the years.
I love that my clients who I've treated years ago still reach out to tell me how they're doing and that they're thriving, and that, like, this work treating OCD is it's the most amazing job you could possibly have
Mhm.
because you get to see people who really feel like this is something that they cannot fix, absolutely find their strength and face their fears. It's the most amazing experience to see this and to watch them recognize that about themselves. So, yeah, treatment is hard. Any treatment is hard, right? No, OCD treatment is no different, but it also works. And so, when you really do it, I really have seen lives turned around. And then the other thing that happens sometimes is that people are so grateful and happy that it's worked so well, they will become OCD advocates
Mhm.
themselves. And I love traveling with those folks in my life and really knowing them and watching them thrive and kind of share what they've learned with other people. It's so powerful. So if, just to sufferers, if you have OCD, don't hesitate. Really go and see if you can find treatment and start learning at the very least about it. And if you're a treatment provider and you're really interested in doing this treatment well, go ahead and get consultation and start to learn yourselves because it really is, it's an amazing gift to have a treatment that works as well as it does, and to make sure that we are getting it to the folks who need it.
Great place to leave things. Lisa, I want to thank you again for being with us today. We covered a lot of ground. You shared some very important information, and we want to thank you again for loaning us your time and your expertise.
My total pleasure. So thank you so much, Jeff.
And to those of you watching, thank you for your interest in our Deconstructing Stigma video series. We hope you'll come back for our future sessions, and we wish you a wonderful day.